All right, today we're going to step into the high-stakes world of medical diagnostics. This is a world where every single symptom is a clue, and every doctor is basically a detective. We're going to crack the code of clinical reasoning by tackling two really challenging cases, so let's see if we can solve them together.
So get ready. You're the one in the white coat today. All the clues you need are right here, in the charts and the scans. It's time to piece together the evidence and see if you can solve these medical mysteries.
Our first case? Well, it's a tough one. It starts with a patient who's experiencing some truly alarming neurological symptoms. Let's take a look. Okay, I want you to just imagine this for a second. For 2 straight weeks, your entire world has been slowly slipping out of focus. That is the reality for our 40-year-old patient. He's confused, his head is absolutely pounding, and his vision just keeps getting worse. Something is clearly very wrong inside his brain. So let's dive into the patient's file. The first huge clue is his poorly controlled HIV. But look, really look, at his CD4 count. These are the immune cells that fight off infection. A healthy person has over 500. He has just 28. 28! This tells us his immune system is, well, it's severely compromised, which makes him incredibly vulnerable to all sorts of infections. This right here is a critical piece of the puzzle.
And here it is. This is our smoking gun. The MRI shows these ring-enhancing lesions in his brain. Now, you can think of these as these bright, glowing circles of inflammation that just light up on the scan. For any medical detective, seeing this specific pattern in a patient with such a crazy low CD4 count, that's a textbook clue. It dramatically narrows down our list of suspects.
So, you've seen the evidence, a severely compromised immune system, and those really distinctive lesions on the brain scan. The clock's ticking. What's your call, doctor? What's the best first move to treat this patient?
If you chose the combination of trimethoprim sulfamethoxazole and pyrimethamine, you are absolutely correct. This treatment goes right after the protozoa toxoplasma, which is our prime suspect here. See, the other options get ruled out pretty fast because they target the wrong kind of bad guy. Acyclovir is for viruses, amphotericin B is for fungi, and metronidazole is for bacteria. It really is all about knowing your enemy.
Okay, case 1 is in the books. Let's move on to our next case. This one starts with an adventure abroad, but it takes a dangerous turn with a really high fever.
And this timeline right here perfectly illustrates the power of a good patient history. Our patient just got back from backpacking in Brazil. A few days later, boom, a high fever, and that very specific, very telling symptom, a severe headache behind the eyes. It's called a retroorbital headache. That travel history is our first major clue. Now, what's really interesting here are the lab results. We see this classic trio: low white blood cells, critically low platelets, and elevated liver enzymes. It's a signature pattern. And then we get the final piece. A test that looks for a piece of the dengue virus itself comes back positive. The pieces are all falling right into place. Okay, so we have a clear diagnosis: dengue fever. But what do we actually do about it? Right now, in this moment, what is the most appropriate way to manage this patient's care? You know, for a lot of viral illnesses like dengue, there isn't some magic bullet cure. The answer is what we call supportive care. This means carefully managing their fluids to keep them hydrated, which is a really delicate balancing act, and closely monitoring them for any complications, especially bleeding, because those platelets are so low. The goal is to support the body while it does the hard work of fighting off the virus itself. So, we followed the clues. We've started the treatments. Now it's time to officially put a name to our culprits and close these 2 cases for good. Our first patient was suffering from cerebral toxoplasmosis. This is caused by a really common parasite that, for most people, just lies dormant in the body. But, and this is the key, in someone with a CD4 count as low as 28, it can reactivate with absolutely devastating consequences, causing those lesions we saw on the MRI. And our second patient, he had dengue fever, a classic mosquito-borne virus you might find in a place like Brazil. His travel history, that unique headache, and that very specific pattern of lab results, they all pointed directly to this diagnosis. So, after solving these 2 cases, what did we actually learn about being a medical detective? Let's distill the core principles that helps us crack the code. So here's the crucial point. Diagnosis is almost never about one single piece of information. It's about pattern recognition. It's about understanding that a patient's history gives you the context, lab results give you the hard data, and those classic clues point you in the right direction. You have to be able to assemble the complete picture from all the evidence. And that leaves us with one final thought. A headache could be anything from stress to something far more serious. A fever could just be a common cold or a life-threatening infection. So in a world of overlapping symptoms, the most vital skill isn't just knowing facts from a textbook, but the art of putting all the clues together to tell the right story.